Thank you for the kind invitation. My name is Simona Balestrini. I've been now working for the last 2 years in Florence at the Mayor Children's Hospital with the Professor Guerrini team. I was working before in London as an adult neurologist, but my main interest has always been rare genetic epilepsy. So what I'm going to talk about today is probably a slightly different topic. So not so much focusing on the clinical aspect, but on the national registry that perhaps many of you will be already aware of, which is the residuals registry that was a great initiative, in my opinion, established a few years ago to collect data on people with SCN1A and PCDH19 mutation. So I'm going to talk about this model of registry for rare disease, giving you some example of the data collected so far for both Dravet syndrome, SCN1A patients and PCDH19, and also the challenges related with the registry and the future direction, including a recent translational project that we had approved. But let's start from the concept of registry, which I think is becoming more and more important for rare genetic epilepsy syndrome. So the definition has slightly changed over time, but not so much in the end. So for example, one of the first definitions in 1974 was defining a registry as a file of documents that would contain uniform information about individual persons, and this information had to be collected in a systematic and comprehensive way, and they had to serve a predetermined purpose. And then we had other definition. For example, in 1991, we had a definition where, again, registry was defined as a database of identifiable person with a clearly defined set of data, and again collected for a specific purpose. More recent, the Agency for Healthcare Research and Quality defined a patient registry as an organized system that uses observational study methods to collect uniform data, both clinical but also other, to evaluate specified outcomes. And these outcomes or purposes should be predetermined at any level, scientific, clinical, or policy. So you can see as there are some recurrent elements in this definition. So we need uniform information and data that should be ideally clearly defined a priori, and then also the outcome and the purposes of the registry should be very clearly stated from the start. And I think the potential of a registry is really great. I think here you can see a nice illustration of a conceptual framework of a rare disease registry that should include many aspects from the start, from when it is designed. For example, the research and development aspect, the patient impact, clinical decision-making, health outcome reporting, who are the stakeholders involved in the registry, and also very important, one should decide what the question of that the registry should try to answer would be. So for example, some epidemiological questions, so how many people do have the disease? You know, the rare disease is very difficult to really have robust epidemiological measures. And for example, is the disease more common in males or females, children or adults, in specific ethnic groups in some part of the world? Important question related to outcome reporting are the perspective of people living with the disease. So what are their experience? What are their more important questions? What are their priorities? And one very relevant question is the natural history, the phenotypic diversity that Professor Vigevano explained very well in the previous presentation. So how really is this variability, this diversity in the phenotype, and what is the natural history? How the disease develops over time when children becomes adult? And what we can do for risk stratification. How can we say already, okay, this patient will have a worse outcome and this other patient will have a better outcome? And how could we eventually predict treatment response, disease severity, and how one could develop new treatments? So these are all essential questions, I think, for any disease, not only rare disease. And ideally, a disease registry could help to answer some of these questions. And what is the difference with clinical trials then in compare with treatment? Well, the difference is that patient registry collect real-world evidence, okay? So these are real-world data from any patient with a given disease. And so definitely the results compared with a clinical trial are more generalizable. And while, as you probably know, in clinical trial, there are very strict inclusion criteria, so you kind of pre-select your cohort of patients, in a registry, any patient can be included, okay? So the phenotypic spectrum is definitely more representative and is broader. And as I said, so you can have specific objective, any objective you may want when you start designing a registry, but usually they tend to fulfill these criteria. So first of all, they can connect patients, family, and clinician, which is always very important, as, for example, we are all here today. This is a very good example. Help to learn a natural history, evolution, risk, and outcome. Support also research at the experimental level, so genetic aspect, neurophysiological basis, and can establish a base for evaluating effect of treatment or medical devices. And on this aspect, one thing that, for example, is becoming important with our existing registry is that we can eventually assess long-term safety and benefit of various treatment. And in this period now, regulators have increasingly recognized the value of disease registry, because a registry can give an historical comparator data for new treatment, and then they can provide also long-term evaluation, especially for safety of the new drugs. So really, regulators are really valuing more and more the importance of registry, especially when the disease is rare, and so registry is the only mean that can allow gathering this data. And so after this introduction, I wanted to present the Residuas initiative that probably you know already, and I need to thank Drave Italia always for providing me with most of this data. So the registry is started as a national registry, but is now expanding at the international level, with various European countries and non-European also in the process of joining this initiative. And then we have quite a lot of Italian centers involved that are actively recruiting and including patients in the registry. So Residuas is an Italian registry of Dravet syndrome and other syndrome correlated with both SCN1A and PCDH19 mutation. The current format is consists of a scientific advisory committee, which includes 10 expert clinicians, an external steering committee for registry management, which is based in Pisa, Fondazione Monasterio, an external advisor, which is the National Center of Rare Disease, the patient association, which was part of the initial design of the registry, which is Associazione Drave Italia Onlus, and 3 patient representatives. The data included in the registry so far includes demographic features, natural history, so evolution over time, clinical and genetic diagnosis, family history, age at onset of seizure, but also of cognitive impairment, mortality, and then ideally longitudinal follow-up on the various aspects, so epilepsy, but also cognitive motor features, and also results of investigations such as EEG and neuroimaging. There are various aspects that try to guarantee a good quality of the data, because of course data quality is one of the main requisites for a good registry. And that includes a set of mandatory fields, a centralized system to check for duplicate case. The registry fulfills the principle, the FAIR principle, which are the principle of findability, accessibility, interoperability, and reusability, which have been established as the kind of main requirement for a rare disease registry. We also included most of the common data elements for rare disease registration that were recently released by the Joint Research Center of the European Commission. And then we also try to adhere to the ontology codes, mainly the UMLS, the HPO terms, and the ORPHANET code as well, which again are a way to try to standardize as much as possible the language and the terms used to populate the registry. Now I'm going just briefly to present data on the SCN1A patient, because this one have been already extracted and are hopefully in the process of being published, but not so much to present the results that probably at the moment don't really say new information on the disease, but just to give an idea of what is a model of a registry that could apply to many other rare condition eventually, and how this data could be used. So for example, for the patient with SCN1A mutation, we then decided to include only patients with the established Dravet phenotype and established SCN1A mutation, and we tried to include data on the general neurological aspects, so neurological examination, EEG data, motor aspect, cognitive aspect, and data on the epilepsy. And so, for example, we were able to see what happened to the cognitive function over time. For example, this is just an alluvial graph that is showing the evolution for each patient at each visit that was inserted and was stratified by age at the first visit. So you can see, for example, as patients with severe impairment in yellow were less represented when the first visit was before the 3 year of age, while it was much more prevalent where the first visit was after the 3 years. And the same was done for many other aspects. For example, the neurological examination, the yellow indicated normal, sorry, a non-normal neurological examination that unfortunately was more prevalent at the last visit of this patient, while in purple here you can see the presence of ataxia that again was more prevalent at the last visit. So these are type of analysis that we apply to see what happened at each single patient over time. And unfortunately, of course, there was an increased prevalence of various comorbidities also beyond the seizures over time in the SCN1A patients. So what do we have so far on the PCDH19 related epilepsies? So far we have 64 patients inserted, and the majority have epilepsy with variable age at onset, but the majority within the first year. And I don't probably need to go over this because Professor Vijayana has already said everything about the phenotype, but so the seizure presentation was variable, seizure cluster was a prevalent feature, and in terms of genetic diagnosis, the majority had a mutation that was a missense mutation, a minority had a truncating mutation, and for other patient data were not available. The curation of this registry, unfortunately, is not yet optimal, so we're definitely working on this aspect. So, for example, the age at the last follow-up was very variable. We had some data on the type of seizure at the last follow-up, and cluster were a persisting feature in this patient, especially cluster of generalized seizures. In terms of the cognitive aspects, so for some patients there was a formal cognitive testing available. For other patients, unfortunately, it wasn't available. So at the beginning, most of the patients still had a normal neurological function. For most cases, this was established just on a kind of clinical basis, so there was no formal neuropsychological testing applied, and another good proportion of patients had mild impairment of the cognitive function. But then data were not really available over time for some patients. We have some data also on the treatment used that was really, really variable, but unfortunately the way the registry is currently designed does not allow to really gather information on the effect of treatment. So this is an aspect we are working about, and in fact here comes the challenges, because it's not easy to really curate a registry. And for example, I just wanted to present you the survey run by the European Platform for Rare Disease Registry, where they did a survey of almost 300 registries for various rare diseases, and they found out that 48% did not have a clear strategy for long-term sustainability, which is one of the main issues with registry. 34% did not have a specific management group. 30% did not share data. And 21% were established without an even clear plan for funding. And so based on this survey, they came out with some almost obvious conclusion, I would say, which is, of course, a main requirement for financial support from the start, motivation of data providers, data quality, which is essential, improvement of communication visibility, because it doesn't make sense to create 10 different registries on the same disease. The registry ideally should be one actually across the world. And in fact, sharing data is an important principle. And of course, so extension of collaboration, and ideally trying to have a common EU, or I would add even worldwide platform for rare disease registry, because this really would exponentially increase the utility of such a registry. And so, for example, going back to our registry, so definitely there are some strengths, which include the fact that it's a user-friendly platform that allow us to collect data on patients with these two rare forms of epilepsy. has already allowed to establish a network of centers across Italy with specific expertise in rare epilepsy syndrome that are collecting data. There are some control steps in place that I show with you to try to ensure high data quality. And so it can represent a unified source for longitudinal phenotypic data with some data on mortality, comorbidities, and development of the disease over time. But we are missing data. We have follow-up that is inadequate, and unfortunately is very variable from center to center. And the registry coverage is not even, because, for example, we have a good representation from the north and center of Italy, and we have very few centers that have inputted data from the south. And that's why we try to start new initiative, and we have a plan, hopefully successful, to improve the current initiative. So first of all, given also the requirement for the new treatment, especially for Dravet syndrome, we are now changing the format. We are implementing new modules. For example, you probably know about fenfluramine that so far has been mainly used in Dravet syndrome, and we know for this drug data on the long-term safety, because this drug was initially started to be used as an appetite suppressant and then was withdrawn from the market because of important side effects on the cardiac and pulmonary aspect. So we need data on safety on the long term. And so we now added this part on the registry so we can follow up people on fenfluramine on the long term. And we hopefully will know more about the long-term safety. We have started collaboration with various centers. For example, as I said, Resistance is a resource that anyone potentially, of course, upon appropriate request and approval by the steering committee, can access the data, use data for research purposes. So, for example, there is this study launched by the French center where they propose a model for statistical methodologies to improve rare disease clinical trial, and they will be using data from residuals. And then we have this current project that we have recently awarded. Professor Guerini is the principal investigator. And this is a project that uses residuals as the main basis. So we will use data of the registry. We will we use this opportunity to improve significantly the current format. And that is by the basically addition of new personnel fully dedicated to the registry. So we will have 3 people from the north of Italy, another 3 people for the center, and I think 5 people in the south. And these people will only be employed to work on the registry and to really work with each single center to curate the registry and to regularly input data, especially for the follow-up. And then we also proposed a translational approach within this project, which will allow us to select specific mutations that are associated with, for example, a typical phenotype or with some specific treatment response, to then study in vitro electrophysiology, so to try to understand better what happened with that specific mutation at the system function, so how that mutation impaired the brain function. But also we will use existing collaboration, one with the group where I'm still working in London, where we are sequencing the rest of the genome in Dravet syndrome to try to understand again the phenotypic variability, and also add neuronal modeling and proteomic analysis, again to try really to understand the specific variability and the treatment response in patients with given mutation. And just to give you an overview of what we are doing in the whole genome sequencing, well, we believe that probably it's now time to think beyond the single mutation. And in fact, we are finding more and more that even people with an established diagnosis, here I'm giving an example of Dravet syndrome, where there is one mutation and a clear core phenotype of Dravet syndrome, there is more than that. And for example, this figure on the on your left is showing a patient with Dravet syndrome, but also a focal cortical dysplasia. And in fact, this patient had a clear start of seizures typical for Dravet syndrome with febrile prolonged seizure and then developmental regression, but then started to have very clear focal onset seizure that responded very well also to carbamazepine, and the MRI showed with this focal cortical dysplasia. And by doing whole genome sequencing, we also found that the PDC5 mutation that is already also reported in other patients with focal cortical dysplasia, and so we could classify it as pathogenic. So this is a typical example of blended phenotype. So definitely one mutation explains something, but then there are other aspects of the genome that explain other aspects. And another aspect that the genome can give us, another information that is in the genome, is the polygenic risk score. The polygenic risk score is a measure that is based not on a single gene, but on multiple genes. So it gives us an idea of the burden of genetic variation that predispose to a specific trait. For example, there is a polygenic risk score for obesity that predicts how a person is predisposed to become obese, for example, or to develop diabetes. And so we applied polygenic risk score for intelligence, for longevity, and for epilepsy to people with Dravet syndrome, and compare these people with other people with epilepsy without Dravet and with other people with disease not brain related. And we found that this was quite interesting, that people with Dravet syndrome, for example, had a lower PRS for intelligence, a higher PRS for longevity, meaning that they are more resilient. In fact, sorry, I didn't say that these were an adult cohort, meaning that these are adults with Dravet syndrome that survived status, survived. Many of these had been exposed in the past to the wrong drugs, such as sodium channel blocker, that are contraindicating Dravet syndrome. So definitely we had some evidence that polygenic risk score can explain other aspects of the disease beyond the single gene mutation that, of course, we know has a large effect on the phenotype. And that hopefully we will also develop this other part, which is basically deriving neurons from human pluripotent stem cell and doing proteomic analysis to try to also understand better how treatment can work in a patient with a given mutation. And there are some examples already published that this is possible, and hopefully we'll be able to select some mutation and develop the same kind of paradigm. So in conclusion, I think that registries are important in rare disease, and we already have a platform that is shareable, is interoperable, and can bridge the gap between the research and the medical care, which unfortunately is still present. And so we are in the process now to extend the data collection for both SCN1A and PCDH19 at the international level, and hopefully we will have additional information, natural history, biomarker, outcome measure, and this may facilitate design and recruitment for new treatment trials. And definitely, delineation of the natural history for rare epilepsy is an essential requirement for novel treatment, because we need to know how we could eventually modify the disease course. And so we hope that the registry could contribute also for the guidelines for management of both children and adults with rare epilepsy, and of course set the basis for translational research. I conclude here. I thanks again Isabella Brambilla e Isaia Giarola from Dravet Italia Ollus, Professor Renzo Guerini and Bernardo Dalla Bernardina, who had been really essential in the design of the registry, and all the other collaborators from Meyer Hospital. Thank you.